It's just like being back at the college. And I just want to say hello to all my colleagues and my friends some of my old classmates and my old students and some current students, and it's always a pleasure to be here. So we're going to talk about interpretation of a CNS report. Everybody has a CNS report coming across their desk with patients that they're seeing. My conflict of interest disclosure, which I have to talk about first before we start. Sadly, I have no financial relationship with companies or no products that could objectively affect this lecture. And as I was, now we're going to find out about the demographics of this audience here. So when I was preparing for this lecture, it put me in mind of an old game show. It was called Who Do You Trust? And probably 5% of the people in this audience have ever heard of this show, or have ever heard of Johnny Carson, or have known that he was on the Tonight Show before our current host. But it put me in mind of that game show, because we, in reading a CNS report, really do a home version of that game show. Who do you trust the most? You know, we basically put a lot of stock in whoever takes that initial culture, whether it be in the OR or the emergency department or the clinic, and we use that CNS report to base our therapy on for days or weeks or months. So I think probably, unless you know who's taking the culture, if they took a good representative culture or not, then you need to only rely on yourself in terms of trusting the person who took the culture. I mean, let's say it was a student or a resident and they took a swab culture, and now that goes into the chart, and now you're basing your therapy for weeks or sometimes longer on that initial culture. It really wasn't a culture of the representative organisms, but was culturing colonizers or commensals. So before we read a CNS report, we need to know how much stock we can put into that CNS report. So this is a CNS report, basically that you'd see in a hospital situation. And CNS reports take on different formats depending upon whether you're in the hospital or you're in a clinic and what EMR that you're using. It looks kind of cluttered and in sort of disarray, but it's really not, though, because what CNS reports have in common are gram stains, and sometimes you have to order gram stains separately. Sometimes they come as part of the package. The organism, these are common to all CNS reports. The antibiotics that they run against those organisms, the sensitivities, which is why we do CNS reports in the first place, the cost, which are the little dollar signs, and all things being equal, you want to choose the less expensive antibiotic versus the most expensive antibiotic, and then the MICs, or the minimal inhibitory concentrations, which we're going to specifically talk about in a bit. But I think this is what we're really familiar with in our office. This is a really bare bones, sanitized CNS report. There's no MICs. It's just sensitive or resistant. This is Staph aureus, one of the most common organisms we see in treating skin and bone infections. And again, which I tell my students, some of them who are here today, when you get a CNS report, you go to Staph aureus, if it's a staph report, and then you go right to oxacillin, and you see whether it's sensitive or resistant. And in this case, it's sensitive to oxacillin, so this is going to be methicillin susceptible staph or methicillin sensitive staph, or MSSA. Now, this particular CNS pattern is representative of about 5% of the strains of staph that we're going to see, because most of the strains of staph that you and I are going to deal with produce beta-lactamase. This is pan-sensitive staph. This strain of staph does not produce a beta-lactamase, and we know that because it's still susceptible to drugs like ampicillin, penicillin, and by extension, amoxicillin. So when you and I treat skin and bone infections, we're never going to use amoxicillin plain. We're never going to use ampicillin plain. We can use amoxicillin with clavulanic acid, because the clavulanic acid protects the amoxicillin from beta-lactamase, and the sulbactam protects the ampicillin from the beta-lactamase. But you and I are never going to use pure ampicillin or penicillin or amoxicillin. This CNS report is pretty much representative of most of the staph that you and I are going to see. Probably 90% of the strains of staph are going to be producing beta-lactamase. So we know this strain of staph produces beta-lactamase because it's resistant to ampicillin and penicillin, and by extension amoxicillin, because it produces a beta-lactamase, and these antibiotics are not beta-lactamase stable. And again, we look at Staph aureus, we go right to oxacillin. If it's oxacillin sensitive, it's MSSA. If it's oxacillin resistant, it's MRSA. So this is representative of the maybe 90% of the staph that you and I are going to see in treating skin and bone infections. Now we're going to look at this strain of Staph aureus. We go right to oxacillin resistant, so it's methicillin resistant. You're never going to see methicillin on a CNS report these days. It's always going to be your surrogate marker, oxacillin. So if it's resistant to oxacillin, it's going to be methicillin resistant staph. And this is CA-MRSA, susceptible to the tetracyclines, read minocycline or doxycycline, and by the leap of faith, clindamycin and trimethoprim sulfamethoxazole. So these are the common staph reports that you and I are gonna see. So Dr. Parker's in the audience. I told her I'm going to give her a shout out, and I went to Dr. Parker earlier this week and I said, Eunice, I'm going to be giving a talk on reading a CNS report. What do you think I should cover? And she goes, make sure that those students and those residents read the correct report. And that's just so important. I know everybody's sitting here thinking it's not going to happen to me, but it will and it can. And now we have a less of a chance of that happening because we're bringing your attention to it. Just like you verify your patient when you bring them in from the waiting room into the treatment room with 2 identifiers, please look at the chart, make sure you're looking at the CNS report of the right patient. It's happened where the wrong patient's CNS has been scanned into the wrong chart. Look for 2 identifiers, the patient's name, the chart number, the date of birth, and don't think it can't happen to you. It's happened to me, and it can happen to anyone. Know the source of the culture. Some of these patients with chronic wounds are going to be treated for days and weeks and longer, and with multiple admissions. And the number of cultures in the chart are just going to be very, very confusing. So know the source of the culture. Did it come from the wound or the bone or the blood or other? In the case of multiple cultures and a long hospital stay or multiple hospital stays, know when the culture was taken. Is it from a current admission or a previous admission? Again, these things get very complicated, especially in our patients who have multiple admissions for a long period of time. And where was it taken? Was it taken in the ED, the bedside, the OR? Take a minute to read this. And you're reading this because the human mind doesn't read every letter by itself. It reads the whole word. It reads the word as a whole. And so your mind makes conclusions. It reads things that it expects to see. It doesn't see things that it doesn't expect to see. You don't see the second "the" in I Love Paris in the springtime, but it's there. And your mind jumps to conclusions. So before you read the culture report, I know it sounds trite, but just make sure you're reading the correct report from the correct source, from the correct date. Here's a patient we saw at Metropolitan Hospital. Nothing special about this patient. One of many, many patients that we see with long admission history. This patient had 13 cultures in 3 sites over 12 months. You like how I made the urine culture yellow arrows, right? That was no mistake. This is a patient who was recently admitted, and I think recently discharged in September of this year. But they had 2 previous admissions, right? One 6 months ago and one actually was 3 years ago if you count back from 2021 to 2024. But in 2 years/3 years ago, the patient had a staph infection. 6 months ago, earlier this year, the patient had another staph infection. And in this recent admission, they also had a staph infection. Let's see what happened to the staph. So in September 2021, almost 3 years ago to the day, this was Staph aureus. Again, go to oxacillin. It's oxacillin sensitive. This is MSSA. Vancomycin susceptibility of MIC of 1. And again, not that you would use vancomycin in a patient with MSSA, you wouldn't. But just take a look at what happens to the vancomycin MICs in January of this year. Again, right foot, left foot, same patient, same skin, but look what happened to the susceptibility pattern. Vancomycin now goes up to an MIC of 2. Everything else is the same. They just didn't run it against penicillin, but everything else here is exactly the same as it was, but the vancomycin is creeping up. Again, you're not going to use vancomycin in an MSSA patient, but it bears looking at seeing the vancomycin MIC going up, creeping up just a bit. Now let's look at the current admission. Patient was recently discharged, I think, early this month. Now look at oxacillin. Oxacillin resistant. This is now MRSA. Look at January, MSSA. Look at September, MRSA, and the vancomycin MIC of 2. Now when we'd want to use vancomycin on this MRSA patient, we really can't. I'm going to talk about this MIC of 2 in a bit. But this is sort of a trap. We're going to talk about this in a few slides. Vancomycin has an MIC of 2. Don't use it. Even though it says sensitive, it's sort of in the gray area. It's approaching the break point of resistance. And they're finding increased clinical treatment failures when patients use a MIC of 2. My point being, this is the same patient, the same skin, left foot, right foot. Again, I'm sorry, right foot, left foot. Again, left foot, and look, now we've got an MRSA 3 years after the patient first came in. So the evolving resistance pattern of this strain of MRSA, you need to realize that the date and the time that you take these cultures from is critical. Let's look at Gram stains. Gram stains are simple, they're rapid, they're inexpensive. The best case scenario is that the culture goes all the organisms identified in the Gram stain, all present and accounted for. But that doesn't always happen. Now we have a Gram stain with no organism seen, but a heavy growth of MRSA, a heavy growth of S. multifila, a moderate growth of Providentia. Isn't it a surprise to this doc who took a Gram stain, maybe not knowing whether or not this was a sterile abscess, maybe depending upon the Gram stain to either continue or discontinue his antibiotic therapy, seeing no organisms in the Gram stain, and yet seeing a heavy growth of MRSA, et cetera? So why does this happen? It probably happens more commonly because we don't submit a large enough specimen, because you need at least 10 to the 4th or 10 to the 5th organisms per ml of fluid or gram of tissue in order to detect any bacteria. And when we deal with the foot, when we deal with toes, little tiny abscesses, maybe touching the tip of that cotton-tipped applicator to that barely perceptible exudate, we're not giving enough organisms, we're not giving enough of a load to be able to see the organisms on Gram stain, and yet it's enough to grow when when that bacteria is in culture. So no organism seen doesn't necessarily predict a negative culture. The third scenario is organisms are seen on Gram stain, but culture negative. So why can this happen? Well, maybe the organisms are present, but they're not viable. Maybe there's previous antibiotic therapy, appropriate culturette. Did we try to culture for anaerobes, but we used a culturette that only supported aerobes? And maybe it's a very fastidious organism. Maybe it's a very difficult to grow organism. This is a poster that I did with a bunch of students back in 2019 pre-pandemic. And we have a poster competition every year. We have for many years, and Scott Millay comes down and judges it. And this is one year where I thought this would be interesting. Let's see the predictive value of a Gram stain for diagnosing lower extremity infections. And we looked at the infections that we had seen at the New York College, FCNY. So these are outpatient patients with mild infections, 212 CNS reports, and out of 212, only 139 patients had true concordance. Now take a look at the right here, this little pie graph. This little pie graph that you can't read is based on a survey that Barry Block did at our request so that we could include it on the poster. Some of you may have actually fed into this and answered this poll. It turns out that when we asked the respondents, did you rely on a gram stain to guide your antibiotic therapy, and we got about over 600 responses, there was 70% answered no and 31% answered yes. So the question is, you think we should be using gram stains more? You think it's a waste of time and money then to actually run a gram stain on lower extremity infections? And I thought about how could we possibly use gram stains maybe to increase our treatment success. And I thought of a scenario. So you can gram stain pretty much anything. You can gram stain tissue, you can gram stain blood, do a Buffy coat smear, you can gram stain cerebrospinal fluid, urine, you can gram stain bone. So you can ask for a gram stain of bone by going back to that histology specimen that you submitted when you took that bone in the OR, et cetera, and you can tell them to do a gram stain on that bone. You're not looking for the viability of the organism, you're looking for their presence. And I thought, what about a scenario where you do a CNS of bone, right? And you wanted to rule out chronic OM, and histology said the patient had chronic OM, right, histologically. And now you did a CNS of the bone, and it came back pure Staph aureus. So now you're planning for 3 weeks or 6 weeks or what have you on an MRSA active agent, but a pure Staph active agent like linezolid or Dapto or dalbavancin. But then you do a gram stain of the bone, and you see gram-positive cocci, which would account for the Staph aureus, plus gram-negative rods, which weren't in the CNS. And now my question is, now what do? Do you then modify your antibiotic regimen to include the gram-negatives that you saw in gram stain but didn't grow on culture? And if you don't, well, then why did you do the gram stain in the first place? So just sort of a thought question for you on how maybe we could be using gram stains more in our practice. Now let's look at sensitivities. That's why we do CNS reports. We do a culture and we want sensitivities. We want some guidance as to what organisms we want to kill. Well, there are 3 possibilities in a CNS report. One's going to be sensitive, one's going to be intermediate, and one's going to be resistant. For our purposes, intermediate is going to equal resistant. Don't use intermediate, don't use resistant. You only want to use a drug that the CNS report lists as sensitive. This is important. These are based on MICs, minimal inhibitory concentrations, and established breakpoints, both of which are specific for an organism antibiotic pair. It would seem logical to assume that you choose the antibiotic when there's more than one antibiotic that is listed as sensitive, that you choose the antibiotic that has the lowest MIC. But that's not the case. It's so not the case that it was listed in Medscape Infectious Disease Edition not too long ago for the question of, given specific susceptibility information for an infectious organism, why can't you simply pick the antibiotic with the lowest minimal inhibitory concentration? That would really make sense. You have to take on faith that you can't do that. And people who got the reference to the Who Do You Trust in the Johnny Carson will get my reference to the robot from Lost in Space. Notice how I put the apple and the orange down here. So you can compare apple and oranges. It's that the MIC that you see on a CNS report is unique to the antibiotic organism pair. It's in a vacuum. You can't compare one MIC against the other. Okay, so for our purposes, you can take your hand and cover up the MICs on a CNS report and never refer to those MICs, and you will not be the worse for wear. So how do you choose between more than one antibiotic that's represented as sensitive if you're not using the MICs? We're going to go to number 3 here in the 3 principles of antibiotic selection. Once sensitivities are known, i.e. once you get your CNS report back, choose the narrowest spectrum agent with the best efficacy, the lowest toxicity, and all things being equal, the lowest cost, but don't use the MICs. Use the merits of the antibiotic, not the MICs. So let's go back to our CNS report, back to the patient that was admitted earlier this month with MRSA, oxacillin resistant. And let's say, well, should I choose gentamicin over linezolid? Gentamicin has an MIC of 2. Linezolid has an MIC of 4. Maybe I should choose Gent because it has a lower MIC. But if you take your thumb and you put it over now on the screen over so that you can't read the MICs, now the choice seems relatively clear because gentamicin is ototoxic and nephrotoxic and linezolid isn't. Suppose I want to use linezolid versus vancomycin. Well, I'm not going to use vancomycin over linezolid because vancomycin has a lower MIC, because I just told you using a vancomycin with an MIC of 2 is a trap. You have high treatment failures at that MIC. You might want to choose linezolid because it's not ototoxic or nephrotoxic for other reasons, but you're not going to choose one drug over another because it has the lowest MIC. Look at rifampin. Rifampin has an MIC of 1. It beats everything above here. Maybe rifampin is the best drug, and I just need to put the patient on rifampin. But we all know that putting a patient on rifampin is not something we do as a single-agent therapy because rapid resistance can develop. So you get the idea. Choose the antibiotic on its merits, not the MICs. And here's my vancomycin MIC caveat. Don't use, for those of you who are in the hospital and use vancomycin, for the residents, don't use vancomycin if the MIC is greater than 2. You'll see if a patient has MRSA in the hospital and it comes back with an MIC equal to or greater than 2, even though it says sensitive, ID takes them right off, puts them on daptomycin or linezolid or similar, because they've had an increased rate of treatment failures at this MIC and you need to use alternative agents. The last thing I'm going to talk about is MDROs, multi-drug resistant organisms. So an MDRO is an organism with decreased susceptibility to multiple classes of antimicrobial agents to which they normally would be susceptible. MRSA is characterized as an MDRO. So MRSA is the most common MDRO in the gram-positive world. In the gram-negative world, it are gram-negative organisms that produce ESBLs. And ESBLs are defined as extended-spectrum beta-lactamases. And the reason why they call them extended-spectrum beta-lactamases is that it's a beta-lactamase that inactivates extended-spectrum cephalosporins. So ESBLs can hydrolyze penicillins. Well, they're a beta-lactamase, and penicillins are beta-lactam antibiotics. Extended-spectrum cephalosporins, by definition, are third, fourth, or fifth generation cephalosporins. Monobactams, which are beta-lactam antibiotics, and we use them to treat gram-negatives, unfortunately, like astrianum. And other favored gram-negative killers like aminoglycosides, trimsulfa, trimethoprim sulfa, and quinolones, which we also rely upon to treat gram-negatives, are also unreliable. And now we have a therapeutic option left, which we've used for years for severe gram-negative ESBL producers, and those are the carbapenems. Well, let me show you a CNS report now that you know what an ESBL is. This says Klebsiella pneumonia, which is a gram-negative, and ESBL, which is an extended-spectrum beta-lactamase. So this strain of Klebsiella produces an extended-spectrum beta-lactamase. So it's inactivated, pardon me, the extended-spectrum cephalosporins, the third, fourth, fifth generation cephalosporins, ceftazidime, ceftriaxone. It's also inactivated trimsulfa and the quinolones and astrianum. And thankfully, the carbapenems are still left to use on this patient, right? So we have meropenem and we have imipenem. But there's more, and this is the last slide. There's always more when it comes to resistance. Years ago, we had a student who was a physician in Egypt, and he still maintained his ties to his other physician friends in Egypt, and he shared this CNS report with us, and I thought it was very interesting to share with you today because it shows that resistance is such a worldwide problem. This is Klebsiella pneumonia, right? Klebsiella pneumonia from a hospital in Egypt. All of the X's equal resistance. The only thing that's susceptible to is colistin. So this is carbapenem-resistant Enterobacteriaceae. This is a strain of Klebsiella that produces an enzyme to inactivate carbapenems. And I told you, carbapenems were a go-to antibiotic for ESBL producers. Now what are you going to use? You're going to use drugs like colistin, which are so nephrotoxic. We used to use a lot of colistin back in the day, but we stopped because it was in favor of another drug that we stopped using colistin. It was gentamicin. Well, if you're using colistin because it's too nephrotoxic in favor of gentamicin, it tells you how nephrotoxic colistin must be. So now there are other drugs that are being developed to target these carbapenem-ACE-producing organisms. But just to show you what a problem resistance is and bring you up to speed. So things to remember: the lowest MIC doesn't mean the best drug. Resistance to it should have said oxacillin. Resistant to oxacillin is MRSA. Resistant to extended spectrum cephalosporins, the third, fourth, fifth generation cephalosporins, is presence of ESBLs, or extended spectrum beta-lactamases. And use vancomycin alternative for MRSA if the MICs are greater than 2. I hope this helped in some way, because we all read CNS reports, and this is common to what we do in our daily lives. I'm sorry for going over a little bit. But thank you very much, everyone.